Good afternoon, officially, yeah, right? Good afternoon, everyone. Thank you for coming. Hopefully, you're having a good time listening to all the spectrum of interventional cardiology. So, we're going to switch a little bit to another subspecialty of interventional cardiology, which is really up and coming. Some people are interested. I know it's a lot of structural driven right now, but one of the other aspects which probably would play an important role in your career if you plan to do more of private practice setup or in the private world is dealing with peripheral arterial disease and endovascular intervention. So for the guys who really want to make the real money, that's where it is. All right. So I'm just going to give you a brief overview. I'm just going to run by the slides. The idea is to try to give you, I don't know how many of you are second years, third years fellows, third year fellows, general cardiology fellows? Any interventional fellows? Okay, good. So I'm sure you probably are getting an exposure to PAD world in your setup or in the process and hopefully get it. And before I go ahead, if anybody is interested down the lane to do any, nowadays like structural heart disease that require an additional dedicated ear, so does endovascular in most of the fields. If you really want to be good at it, sell yourself and be an expert in it. So if you are anyone, if you will be interested, or anyone if you know want to do endovascular fellowship, we actually have 3 spots, the largest in the country. So we do an extra year of endovascular interventional fellowship after your interventional year to give you all the exposure. And we'll have a few of our fellows hang around with you. If you have any questions, concerns, you can talk to them. All right, so the reason we're going to talk about PAD today is, as we know, the atherosclerotic disease is pretty prevalent. Even though this slide is older, you can actually see the trend of PAD is pretty much as comparable to for people who have CAD and cerebral vascular disease. The problem really arises is, I hope I'm loud enough, the mic is all over here. The problem really arises is most of the times the patients who present with PAD, half of them are asymptomatic. So people don't even know that they have the disease, even though the disease might exist, but because of the lack of symptoms is what the issue is. And you can see this data slide being older, but the present data says there's an consistent increase in trend for the wrong reasons, that the prevalence has significantly increased in this country. And this also, the prevalence can be also be done by the partner study, which shows almost 29% of people who have PAD if you do just a general survey among the population. And as you can see, as and how you get older, like any atherosclerotic disease, whether it be CAD, CVA, whatever you want to call it, the PAD also significantly increases as you grow older. Men obviously worse than women, but at the end of the age, the women take over men because of their longevity. Highlighting how the breakdown is on this on the disease per se. The blacks unfortunately have the highest prevalence, followed by non-Hispanic whites and Asians being on the lower side as well. And this is just pretty much like a Venn diagram describing how CAD, PAD, CVD have an overlap. And if one has one disease, it's always good to be cognizant of the fact that the other component of the disease might be present, which might not be highlighted when they present, but you should always be there to at least identify and ask a question about that. So if you have, if a patient presents to you in clinic, which is your coronary clinic, and any of these risk factors, it's always beneficial, especially from a physician's perspective, professionally and personally, to try to see if they have underlying PAD as well. And these are the defined risk factors which everybody knows about. But look at the relative risk. If you're a smoker, the relative risk of having PAD is almost 6 to 7 times as compared to who doesn't smoke. And a permutation and combination of them actually makes it even worse. And the reason we are so concerned about PAD is purely looking at the all-cause mortality. Somebody walks in, somebody gets diagnosed with PAD. If you're asymptomatic, look at the relative risk right there in the second last column. You can see it's almost 2.2. But if you're symptomatic, it actually goes to 2.8. So pretty significant for people who are presenting with PAD. Your mortality is definitely higher than somebody who doesn't present with one. So that's why it's one of the important disease processes for you to identify them and treat them in the right time. And the reason, again, we emphasize on PAD as well is your long-term mortality, your long-term survival is directly correlated to the patients who are presenting with this format of disease. The risk factors we talked about, the prevalence we talked about. Now, we know most of the patients you'll encounter have a lot of diabetes and PAD as well. So this is the worst combination. If you have PAD and you're diabetic, at the end of 14 years, only 20% of the patients really survive. 80% of them are dead, essentially, for whatever cardiovascular reasons it might be. So this is one of those important determinants or factors or the relative risk I talked to you about before is important in determining what is your cardiac mortality. Because at the end of the day, being physicians, our goal is to make sure we improve not only their morbidity and quality of life, but also change their mortality. And that's the reason these are one of the important factors as well. The good thing is that if you have PAD and claudication, the progress of the disease is not as bad as you would expect. So let's say you get diagnosed with PAD, 73% of the patients remain as claudication presentation, and they remain stable. So it's not that if you don't fix it, it's eventually going to have their leg amputated. But there's a 16% of those population which can actually progress, and approximately 4% of the people actually end up in amputation. But this is where the whole cycle goes in, where if diagnosing in time and treating them, you can actually prevent the progression as well as change their mortality as well. This I don't have to tell you as a general cardiologist and interventional cardiologist of how the presentation is of asymptomatic, atypical, typical, and the acute limb ischemia. But this is one of those important classifications for you guys to know once you're practicing, and also for the exam is either they come in as a Fontaine classification or a Rutherford classification, and how to interpret it. So let's say they say a patient comes in Rutherford grade 4, what does it mean? It means that the patient is having rest pain. If it comes in with type 3 or type 2, then it all depends on the claudication part of it. So these are important classifications for you to know. All the slides will be up for you to review, so there are more than adequate slides for you to look into it. We talked about the presentation, the vascular symptoms as well, but the most important part as being a physician, as being a cardiologist, as being an interventional cardiologist is a comprehensive examination. I understand everybody is busy, everybody's in a rush, you quickly want to diagnose, see a patient, 15 minutes, go out and see the next one. But a good comprehensive vascular exam is the essential core for the diagnosing and probably ordering the right kind of testing and the treatment modality as well. So if you think your vascular exam is adequate enough, then you can actually say the patient has PAD or pseudo PAD, whatever you want to call it, and then progress in the same direction. So these are some of the differential diagnoses which you've been learning from your internal medicine time. So this is pretty much what the differential is, and difference between claudication and pseudoclaudication, pretty much standardized textbook definitions which we need to know just from the exam purposes. The most important thing, like I talked about, is not only in the diagnosis, is not only physical examination, but also trying to confirm your suspicion or your clinical exam. This is one of those brief questionnaires which we can actually use in your clinic when you go into practice in order to start a PAD practice, where you can actually throw out a few questions to your patient and say, okay, how am I going to catch these patients who have PAD? This is a brief introduction to say if any of these are positive presentations, then at least you can start asking or start pursuing in that direction, and then go from there to see if they truly do have the disease or not. One of the commonest tests which we order, and this is not only important because of the ease of use and an outpatient workup, but also it's a class 1 indication per the latest ACC SCI guidelines in diagnosis of PAD patients, as well as you'll see when you go into practice, that most of the insurance companies also need ABI as the first test to really determine if the patient has your underlying suspicious diagnosis of peripheral arterial disease or not. So ABI, I'm sure you all guys know, is pretty much a simple mathematical calculation where we see the lower extremity systolic blood pressure the highest, whether it be the dorsalis pedis or the posterior tibial artery, and the denominator being the highest brachial pressure, whether it be the left arm or the right arm, whichever needs to be taken care of. So it's a simple test with 95% sensitivity, 99% specificity, easy to diagnose, easy to use, very simple testing with minimally invasive stuff. So this is just for your exam purposes. If they know what's the ABI on the right and the left, you have to get the highest pressure, not the lowest pressure, but the highest pressure of how you determine or how you calculate your ABI. So for the right leg, you want to do the right ankle pressure with the highest arm pressure, whether it be left or right. And for the left leg, you do the highest left ankle pressure and divide by the highest arm pressure, whether it be the left brachial or the right brachial artery. And then depending on what your numbers come in, we actually classify them being normal, abnormal, highly, or intermittent, depending on their presentation. So anywhere between 1 to 1.29 or 1.3 is normal. Anything less than that is considered abnormal, and anything less than 0.4 is considered as severe disease, which calibrates or which equates to your rest pain, which is Rutherford grade 4. So another important parameter is that the numbers have to match the symptoms. You can't say a patient is having rest pain and his ABI with the waveforms is perfectly 1. It doesn't matter. Then that's where you start to think about alternative diagnosis or other symptoms as well. This is, again, classifying those abnormal numbers into whether it's mild to moderate disease, severe disease, or even pseudo-normal disease. The reason ABI is important, again, even though it sounds as a simple mathematical calculation, is it has a direct correlation to mortality. as and how you see, as and how your ABI numbers start to go down, your mortality, both your all-cause mortality as well as the cardiovascular mortality starts to significantly go up, both in the direction. So the ABI is abnormal, meaning more than 1.3, which, as you know, is more commonly seen in diabetic patients who have severe calcified non-compressible vessels. In those patients, as well as patients who are zero point 0.9 or less, there is a direct correlation with mortality. So these numbers are not only for you to get an insurance authorization or for you to diagnose and treat it, but actually look at the long-term outcomes as well. But of course, like any test, it comes with its own limitations, which you can go down here. Incompressible, resting ABIs could be like having a resting echo without a stress test. You might have to do other modalities to really confirm your diagnosis. If your suspicion is high, but the test is not corroborating to your findings or symptoms. So you can do a TBI, you can do ultrasounds, you can do MR, CTs, whatever modalities is present for you to help in diagnosis and treatment of these things. So like we talked about, if you have intermittent claudication and you just follow up these patients, you can actually look that your mortality actually goes up as and how the time, the survival goes down, the mortality goes up as and how the time progresses as well. So the important goals of therapy or PAD is to first to identify, prevent the progression, and of course modify the atherosclerotic risk factors. And then we're going to talk about the intervention aspect as well. So improving walking distance is the most important thing which we look for. We all know about the non-interventional or non-invasive strategies, smoking cessation being very important in these patients. There is clear data to suggest smoking worsens progression of disease, increases mortality. Antiplatelet therapy, as you all know, most of your CAD patients are already on, but if not that, they also have beneficial or cross-benefit in PAD as well. So there are multiple studies which we can talk about, the Kapur trial clearly proving that Plavix worked better than aspirin, and that was pretty much driven by the PAD arm of the study, and even though the all-cause crossed the bar, it was the PAD arm that actually drove the whole better outcomes with Plavix as compared to aspirin. Blood pressure control, cholesterol control, diabetes management, we all know about. The compliance of the patients has always been a limiting factor. This is an older data. Now it's much more improved, but it's always important to have these patients on your antiplatelet therapy and on your statins as well as your ACE and ARB inhibitors as well. And there is all data to suggest how blood pressure, especially from the HOPE study, has proven beneficial in PAD. The role of statins. There is a direct trial, which is a randomized trial, which actually showed that as and how you increase your statin levels, the walking distance, which is one of the more important parameters, especially in patients with claudication, it actually improves. So if you can see here, the placebo arm, which is in green, has the worst outcome. However, the pain-free walking distance in an 80 milligram did much better as compared to a 10 milligram. So even any kind of statins really works. Silastazol, which is Pletol, you all know, even though it's called an antiplatelet agent, it has multifactorial, multi-level effect. And this is important for you to know from the exams perspective as well. It's not only an antiplatelet activity, but it also has anti-thrombotic. It's a direct vasodilator. It actually increases the heart rate. And this is the problem, is it is technically contraindicated in patients who present when acute heart failure or class 3, class 4 heart failure is technically not indicated in those patients. It also increases the HDL, decreases the triglycerides. So it's a multifactorial effect with good outcomes for patients who can tolerate it. You will see like around 6 to 18% of the patients, the commonest side effect is tachycardia. So if your patient cannot, the ideal dose is 100 milligrams twice a day, but if your patient cannot tolerate it, you can actually go down to 50 milligrams twice a day and have better outcomes from there. This is again the data to suggest how silastazol works much better. 100 milligrams better than 50, better than placebo trial. One important medication which you all know about is Xarelto, rivaroxaban. All the data is coming from the COMPASS trial and the Voyager PAD trial. I'm not going to go into the details, but essentially it showed a beneficial effect in major adverse limb effects and major adverse cardiovascular effects in patients who were on rivaroxaban, 2.5 milligrams twice daily plus aspirin as compared to who were on just aspirin alone. So these are all the COMPASS trial. I'm not, like I said, these slides will be available for you to review. But essentially what they showed that rivaroxaban, and this is the Voyager PAD, it actually did much better in the rivaroxaban arm, where the incidence was statistically much lower in these patients who had PAD as compared to somebody who was not a rivaroxaban. So actually 4 weeks ago, the guidelines of the recommendations came up where use of Xarelto 2.5 or rivaroxaban 2.5 milligrams twice daily is now recommended in patients who have PAD and who can actually tolerate it as well. We talked about all the factors. One of the important things to consider, which is per the guidelines of this Class A recommendation, hard to find, hard to do, but still as a part of your exam and recommendation, is the first treatment of choice in patients who are presenting with intermittent claudication is what we call a supervised exercise therapy. So what it curtails is you have to have 3 to 5 supervised sessions a week, 35 to 50 minutes of exercise per session on a treadmill. I don't know, as regular, normal people, we don't do it. Most of them would not be doing it. If I do a survey here, so it's hard to convince the patients to do it and find a facility to do it. And the problem is it's not reimbursed. So there's a multifactorial of why this is not pursued as well, but purely based on guidelines and recommendations and for your exam purposes, this is the first treatment of choice, besides, of course, controlling your risk factors of how these patients respond. But there is clear data to suggest that your walking distance capacity increases with use of supervised exercise therapy. Pentoxifylline, no more in use. Just for your information, it was an old school medication for vasodilatory effect and thought to work. I've seen a few still physicians, old one prescribe it, do not prescribe it. It's not recommended. Wrong. The only time I can say my boss is wrong is now.
I just prescribed yesterday.
See? The only time, even Barman does. The only time, and there is clear data to suggest that silastazol and supervised exercise therapy works much, much, much better than pentoxifylline. So
the problem is patients are on tap.
Correct.
And then you do what?
Silastazol. So, yeah, you can add silastazol unless you think they're at a very high bleeding risk, even though it has antiplatelet activity is not as strong, but because of the multifactorial effect, it really does have its own benefit in PAD, especially walking distance. So somebody in claudication on DAP and can't tolerate silastazol, try it. If they can't tolerate it, at least we say we give it a shot. Right. So let's talk about some intervention surgical arms of how do we do from an interventional perspective or people who are trying to go into endovascular therapy and arm. So initially our world started with just with balloon angioplasty, but there is significant progression in a good way of how treatment modalities are now available, present, and in use. We've sent from PTA, now we do atherectomy, stenting, DCB, and all other factors. So this anatomy, everybody knows from an interventional perspective, your infrainguinal, suprainguinal, infrapopliteal, suprapopliteal, below the knee vessel. So I don't have to tell you. But nowadays, nobody really does PTA. It's like the coronaries. Nobody really does balloon angioplasty unless it's very small vessel or you're not able to deliver. But the goal has always been to provide definitive therapy, and balloon angioplasty nowadays doesn't really count as definitive therapy. The reason being, you can see the patency rate is 37%. So it's like better not to do anything. The chances of him coming back are much higher when you do a balloon angioplasty. So that's why nowadays balloon angioplasty doesn't really work as much as we do. So we have devices which you'll hear about, which are adjunctive therapy and definitive therapy. So atherectomy is an arm or armamentarium of these devices which help you in treating of lesions. So they help you in plaque modification, they help you in decalcification or decreasing the calcium level, they help you increase the luminal gain, and of course they help you in providing a definitive therapy, which might be drug-coated balloon or stent, which we'll talk about. So these are the few atherectomy devices that are present. The types, usually we classify them is like directional atherectomy, orbital atherectomy, rotational, laser, and of course you heard about intravascular lithotripsy or shockwave, which I'm sure you all have been exposed to by now. So just to give you an idea of how different forms the atherectomy devices come in, the idea again behind all these atherectomy is plaque modification. So you have a rotablator, which is by the Diamondback CSI. It essentially is like the coronary rota. It spins around the wire and it just cleans your plaque up. You have orbital atherectomy CSI, which pretty much circumferential takes the whole radius of the vessel. The idea being that it actually cuts it. It prevents the normal segment and differentially cuts onto the lesion or the plaque. So pretty much it's not only spinning around the wire, it's actually spinning around the whole vessel. So it's essentially clearing up as much plaque as possible right here. You can see the animation. We have directional atherectomy as well. So in this case, this is by Medtronic, and here you're going to see is the catheter goes in. It has a blade which runs at around 13,000 RPM, which is going to show you, and you can cut through the plaque. So that's your blade right there. You click it open, the blade opens up, it spins, and then what it does, it shaves the plaque off, and you collect it in the basket right there. So you can see the basket at 12 o'clock or whatever, 2 o'clock, and all it does is it's shaving a plaque. The advantage of here is you can actually directionally do it per your own requirements. So let's say the lesion is only medially or laterally, you can face your device in a certain way, and then that way you can cut it only in the medial or lateral or the area of interest rather than cutting everywhere else. Orbital atherectomy also says that, but you don't have control in these things. So every atherectomy device has some utility. This is another one which not only does rotational atherectomy, but it actually sucks out the clot. So it's good for patients who have mixed morphology, meaning you have a plaque and you have a thrombus. So I don't want the plaque to be out, but what happens to my thrombus? Who's going to care of the thrombus part? And in this case, you can use this, what we call as a Rotarex, which is an active aspiration. So it not only pulls the plaque out, it also pulls the thrombus out, thereby technically decreasing the chances of your distal embolization or going down your leg. So that's the whole idea about the Rotarex. Everybody, I'm sure you know about the intravascular lithotripsy shockwave, very commonly used in coronaries, but more before that, it actually got approved for using in the peripherals as well, based on the multiple trials, which we can talk about. Disrupt PAD 1, 2, 3. 3 was the real randomized trial, which showed a beneficial effect. And the way this works is essentially generating these sonic echo beams, causing microfractures in the calcification, increasing the elasticity. So technically, it's not doing any plaque modification. So you're not shaving the plaque out. What you're trying to do is just making sure highly calcified segments, they get the 50 millimeter pressure gradient. It causes microfracture. And then you can deliver whatever other devices you want to do, whether it be drug-coated balloon, whether it be your stent or another atherectomy devices, thereby increasing the chances of patency. Because I'm going to show you from the data that it actually shows that there is decreased dissection, which this we talked about. Again, microcalcification, breaking all under your microscope, pre-treatment. And the idea is essentially to expand and collapse these vapor bubbles for 50 atmosphere and then go from there. Again, like I said, we increase the vessel compliance, decreasing the chances of your dissection. The biggest problem we end up doing stenting or DCB more in the peripheral arm is if you have a lot of vessel dissection or what we call as flow limiting dissection. In those patients, we are committed to putting stents in. So as a peripheral endovascular interventionist, our goal is essentially most of the people follow this rule called as nothing left behind, meaning we try to avoid putting metal or scaffold in unless we really have to, because we are lucky enough to have other options like drug-coated balloons, which have shown good patency results. So you can actually see the whole thing is, and the good thing about lithotripsy is mainly breaks only the calcified, not the non-calcified segment. So you can see the superiority of the procedure that compared to balloon angioplasty is much better. Atraumatic chances of dissection, which is type C, which is flow limiting dissection, is less than 77%. Requiring other submaximal pressure is also there. Embolization, perforation, thrombus was 0%. So there's good data to support use of this device as one of these adjunctive therapies. And as always, as interventionists, we are always concerned about, I know all this looks great, but what about my patency? If I'm using it, am I giving real, true clinical benefit to the patient or not? And the data is there to suggest that the primary patency of using a lithotripsy with drug-coated balloon, of course, because they had to have some definitive therapy. Like I said, lithotripsy is just an adjunctive therapy, versus our standard balloon angioplasty with DCB, they did much better in patency even at the end of 2 years. So good data to suggest the use of it. And this is just another video to show you on how hard things, it really blasts, cracks the calcium on your left side, and calcium falls up. While on the other side, you can actually hold this device and fire it, and nothing is going to happen to your fingers. So it's pretty selective in its functioning with good beneficial effects. This we don't have to really know. If you don't have to, this is just pretty much what we can call a comprehensive slide to see all the therapies that are available in the PAD arm, all the way from using the stents to drug-coated balloons to bare metal stents. And you can see if on the left side, if you use the stenting or the drug-coated material, the results are much better as compared to if you start doing plain old balloon angioplasty. So I'm just going to quickly talk about the stents and the balloon, and then I think my time should be up soon. But here there is enough data to suggest, I'm sure you know about this stent called a Supera stent, which is a nitinol self-expanding made from a single wire. You actually have to create the stent in the body as in how it's made. So it doesn't get preformed where you put on a balloon, you inflate the balloon and the stent just deploys. You actually have to create a stent because it comes in a single nitinol wire, and that's where the technicality lies on. But it's very good in patients who have a lot of calcified lesions, and also on patients or areas of hinge, like popliteal segment and the common femoral, where you know that the stent fracture rate might be higher. It actually has really no stent fracture rate. So you can see on how on a fluoroscopy, you can see how the stent bends. It's very flexible, conformable, and durable, and it takes the shape of the vessel. So look at this. If a normal stent on the right, you can see the kink, the nick, and the possibility of a fracture. while on the left side, which is the supera stent, it takes the shape of the vessel as well. This is just to give you an idea of how the stent came into being based on their superb trial, and now they have 1, 2, 3, and a 5-year results, which actually shows that the primary patency across the spectrum, whether you have calcification, whether you have location, all are significantly much better, especially target lesion revascularization and patency as well in all these lesions. Another stent you're going to actually see is what we call as the silver stent. It's a stent by Cook, which is a drug-eluting stent. It has, again, a nitinol background with a paclitaxel medication on it, based on what it is. This was, again, approved based on the Silver PTX trial. They also have a 5-year result. They compared balloon angioplasty to stenting, and the people who failed angioplasty, they compared drug-eluting stent versus bare metal stent. And in both the arms, you can see all the way down to 3 years and now to 5 years. The primary patency in the red arm is much, much better as compared to balloon angioplasty in the black arm. And for patients who did cross over to getting a provisional bare metal stent, actually also Silver did, which is the drug-eluting stent, did much better than the bare metal stent. Again, to give you an importance, which we've learned from Corney as well, that drug-eluting technology is a better technology to use in. It was scarce and hard to find in the peripheral arterial disease, but now it's making a good evaluation as well. So it not only helps with your restenosis, but it actually gives you good results as well. And then, of course, there's data to suggest the economic viability of using a little bit more expensive stents than the other. So another stent, which is the other stent which is approved in the US, is the Neluvia stent. So this is another form of stent, same drug-eluting technology with paclitaxel on it. They were actually bold enough to do a trial to compare them head-to-head to the Silver stent. So normally Silver compared themselves to balloon angioplasty, which is the standard of care. You always want to compare the newer technology to a standard of care and to prove that at least is non-inferior and hopefully superior to it. So balloon angioplasty being the standard, but these guys had the courage to compare themselves to Silver, which was the stent we talked about, which was the first stent approved, and they actually showed better patency results even at the end of 5 years as compared to Silver as well. So even though it's a little bit more expensive stent, if you can use it, the patency rate of this stent based on the trial is much, much better than the Silver as well. And this is based on the Imperial trial, which I'm not going to worry about. But again, primary patency, TLR, and 12-year patency is good as well. And then finally, I'm going to talk to you about drug-coated balloons, which has been up and running here for a long time. And now, unfortunately, now coronary drug-coating technology has been used as well, which they're going to talk about. So again, this drug-coated balloon technology, we started from scratch, meaning we are all on the paclitaxel part of the world, still evolving with new trials coming up on the Limus technology, but they had to prove paclitaxel first that it works. So there are multiple, this was the initial landscape. And technically, what these drug-coated balloons have these 4 components. They have a platform, they have an anti-restenotic drug, they have an excipient, which is how it's going to elute, and they have a coating process to make sure the drug stays on when you go in. So these are the 4 important components of any drug-coated balloon technology. These are the different balloons that were available, but right now from the US perspective, we have the Lutonix, the Impact, the Ranger, and the Stellarex. 4 of them have been approved to use. Everybody comes in their own mix and match fancy paclitaxel dosages, and the excipient is a little bit different modality, but the whole thought process is the same. You want to make sure they're deliverable, they're durable, and the uptake of the medication which you're trying to deliver has to be there because it acts on the smooth muscle of the vessel as well. These are the 4 that are approved. There is enough data to show that drug-coated technology, this is the Lutonix, this is the Impact, shows that drug-coated technology does work across the spectrum. Again, one can say one balloon, there is no direct balloon correlation, so I cannot tell you really that one balloon is superior than the other. It'll be wrong for me to say because there's no direct data, but even if they claim all pretty much across the spectrum, they do much, much, much better. The last thing I'm going to talk about is, I know this is another topic, is critical limb ischemia, which I'm not going to cover. That will probably cover once you guys become interventional fellows or start practicing more of your critical limb, is below the knee intervention, which everybody knows has been the Achilles heel of the peripheral world where there is no real treatment. And this is the latest technology we actually use, has been approved recently, and we were actually the first one in the US to use it. It's called the Esprit bioreabsorbable scaffold. So technically it's a scaffold, not a stent, because it gets reabsorbed in 2 years. So it's like a stent technology which we use, again, it has a reabsorbable scaffold, it has a Limus drug on it, and and then when you use it in 2 years, it's technically everything is gone. Our biggest concern is when patients present with below-the-knee diseases, are we destroying the bypass targets? Because wherever you put a stent in, you're technically ruining because the surgeons cannot go in and deploy a stent, deploy a graft at the stent portion. They have to go more distally down. And there is enough data to suggest as and how you start going more distally down, the patency rate of these grafts go away. So our goal as interventionalists is try to make sure the patient has a plan B in case our reabsorbable technology does not work. So this is just to show you a spectrum of how the stent starts at and how at 48 months, nothing is left there and it's pretty much like a normal vessel going down. And there is enough data to suggest they did a randomized trial, which, like I said, you'll have the data on, but they did a multi-center, multi-world trial, which actually proved that the patency rate of these vessels, especially the limb salvage, which we want to prevent is the amputation, was significantly much better, statistically significant. You can see people having primary patency of 74% versus 43.7% at the end of more than 3 or 4 years. So again, a safer, newer technology to use with superior efficacy, with minimal side effects, and nothing compromised. So finally, just some points to remember. PAD is a common disorder. Start looking for it, especially like I said, once you go into your practice, it will add a good chunk of patients who would have it. And if you try to identify, try to treat them, they will be very thankful. They'll come to you. You'll give them a complete, comprehensive, what we call as cardiovascular evaluation rather than cardiology only, even though all of you will be cardiovascular board certified. So that's one thing I always tell people to do. Smoking cessation is important. Refer to a vascular specialist early for the diagnosis and treatment. And try to consider endovascular approach. And that's my take on it, even though surgical options do have part. Any questions?
Oh, there is one board question. If the ABI is abnormal, what is the next step? Peripheral angiogram or do another some non-visual testing?
So if the ABI is abnormal with classical clinic symptoms and if it's claudication, you recommend them for supervised medical therapy, like I was telling you, exercise therapy, that's an option. So intervention is always plan B in case to all your non-interventional modalities. So if the patient has been statin, ACE, if you cover all your non-invasive modalities, then the endovascular arm will happen. But from a question perspective, they were always going to give you is you put them on exercise therapy, you send them for no medical management, you add, let's say they're not on statin, you add statin or endovascular intervention, you always do supervised exercise medical therapy as the first treatment of choice in patients who are presenting with claudication. Now, if somebody has an ulcer, then according to the guidelines, you still get an ABI, but if the ABI is normal, they go for a interventional aspect, whether it be endovascular, surgical, or whatever it might be. So it all depends. And if it's intermittent ABI per on the graph, then you do secondary modality, whether you get a CTA, an MRA, or other modality to really see if your ABI is borderline and if it matches your symptoms or not.
Regarding antiplatelets and anticoagulation, when do you start, if you're not going to do intervention on these people, if there is no other indication of antiplatelet or anticoagulation, when do you give?
So once we confirm the diagnosis based on symptoms and your investigatory test, and you know it's not classic, then you can start them at the same time. Normally, we would recommend starting them on rivaroxaban and aspirin, like how the data suggested, and see how they do. And then if we have to, and if they can tolerate it, then we put them on a Plavix as well. So earlier, we didn't have an option of Plavix, right? So we used to put an aspirin, Plavix, put them together and do fine. But now, since there is enough data to suggest a direct head-to-head randomized trial, we try to see if the patient, let's say, is on a baby aspirin, we would try to see if the insurance approves it, try to put them rivaroxaban because that has shown to actually prove benefit. Data from your antiplatelet is more anecdotal, so that's why we do rivaroxaban. If not, then we put them on dual antiplatelet.
You give 2.5 milligrams.
Twice a day, yeah. I know sometimes the pharmacy will call you like, this is the wrong dose. No, you just have to tell them, no, it's not the wrong dose. There is a dose called 2.5, so they do get educated. All right, perfect. Thank you so much.
Okay.